captured this to the cloud. We are, okay, we are capturing to the cloud as well. So let's get going. I'm delighted to have our Tuesday healthcare discussion, town hall with a few healthcare professionals. It's going to be a good, lively discussion as we usually do. And there are a couple of topics that I have in mind for today that we'll try to focus on. And we first started with very simple discussions about symptoms, about face masks. And doing this for a while now, this is like the 5th week or 6th week, I forget. So we are sort of digging a little bit deeper and having some thoughtful conversations and sometimes creating a little controversy as well. So let's see what happens today. But I do want to call out Governor Gavin Newsom. You know, he basically is talking about the fact that California does not seem to be tapering off. You know, we are still sort of at the top of the bell curve and perhaps sliding down just slightly. And in our county, you know, we are sort of same. I think we are probably at the point of time where we are on the other side of the bell curve. And as per Governor Gavin Newsom, I think he was saying that we are at still the peak levels and we should be starting to slide in a week or two. And so that's not a good story. I mean, we have been here in California, we've been hunkered down for, I would say, just about 5 weeks now, you know, almost 5 weeks. And we should have seen some results from that, but we are not quite seeing that. And in the meantime, we also see that test kits have become the talk. We are also talking about vaccinations, and the reason is purely why and when exactly can we all go back to our regular lives? When will the norm be? In fact, today I had one of the FM radio stations call me and we were actually talking about the norm. You know, what's the new norm? And how would you define that? And when will we get there? You know, whatever the new norm is, you know, when will we get there? So people are beginning to feel the pain, and especially some of the youngsters, you know, like we started a coding program. We call it shelter in place coding. And we had about 300, 400 signups that happened. Everybody's like keen to do something. And I've never had like 400 signups for any event that we did. So a lot of people showed up, a lot of kids showed up. And they seemed like really bored. They were all like very happy that their friends, they were chatting up a storm. You know, the Zoom chat session was like very busy. People just wanted to like chat with people. I mean, people are waiting for social interaction, is what it looks like. And so let's talk about a little bit in terms of, you know, how we are going to get out of this economic downturn that we're all feeling right now. But more importantly, what would it take from the key qualifiers for us to get back to normalcy? So we'll talk a little bit about that. And then we'll sort of ramble as we usually do. And we'll talk about a few different things. We'll get some questions as well. So it'll be a good discussion. So, you know, let's do some quick introductions. And we have Dr. Mihir Meghani joining us for the very first time. And Dr. Mihir Meghani is with Kaiser Permanente. And I've known Mihir for many, many years. Mihir, would you like to just quickly introduce yourself?
Yeah, I'm an emergency physician working out of Kaiser Fremont, San Leandro, Hayward, Union City Medical Centers for about 20 years. Live in Fremont, board member of the Hindu American Foundation as well. Rishi Kumar supporter, done some disaster work as well, part of the US government World Trade Center team. And I was in India after the Gujarat earthquake and Sri Lanka after the South Asian tsunamis. My role at Kaiser right now is PPE procurement for 4 medical centers.
Great. And Dr. Meghani is a force here in the Bay Area. You know, he's a community leader. He's involved with many, many different initiatives. And like he said, he takes the time to get out in the world and he's trying to be of help. And so we'll talk a little bit about PPE. So Dr. Meghani, I have a question for you in terms of, I saw on social media that Mr. Fremont has been the recipient of like 10,000 masks. So would you like to talk a little bit about that? You know, how did that come about and what else have you all been getting?
Yeah, absolutely. So the community has been very responsive to donating PPE, masks, face shields, gloves, gowns, eye covering, etc. That's been useful. And why was this important? Because after the epidemic started, in China and spread around, all the procurement processes, the supply chains were all messed up, and it was very hard to get supplies because manufacturing was down, the transportation wasn't there, but also because the main two companies that actually supplied most of America's healthcare system didn't have alternate sources for manufacturing. A lot of what ended up shipping here, about 50%, is actually not up to the specifications that the box says, or what it says on Amazon when it's being sold. It doesn't meet the requirement that we can use in a hospital. So the communities really chipped in. Many people in the Asian American, Chinese American community initially, because they knew about this epidemic, so their family members in the U.S. had actually bought a lot of supplies. When they realized they didn't need it, they donated it. More recently, Indian community, Hindu communities also contributed, and a few groups I want to mention that we know for sure have helped out a lot. Aps Charities just now in the Bay Area, not just to Kaiser, but neighboring hospitals, has probably given about 25,000 total PPEs between Santa Clara County, Alameda County, police, fire, hospitals. Just to Kaiser alone, there was a 5-digit amount of PPE given. Truly amazing. The VAPS temples in Milpitas. Seva International also has contributed across the country, New York and the Bay Area as well. Tremendous effort, and some other groups as well have contributed. SSF is a Seva Found group. Bay Area Prabasi Bengali group has also contributed. Voice for Bay Area, which is a Indian singing group, has contributed. Many organizations, and it's been helpful. Why was this helpful and needed? Because initially, when we anticipated a surge like New York had, no hospital had enough supplies or supply chains. But because the curve has flattened out, and there's been a lot of, I would say, reduction in unnecessary waste of PPE. The old waste culture of is pretty much gone with PPE now. We're using it very wisely and cautiously. There are enough supplies now for most hospitals to use in case there is a spike. Of course, if all the hospitals that we work at, Rajesh and I work at, for example, had 10 times as many patients over a few days, we'd all be in trouble, but we don't have that. But I can say that based on what we know now, we're okay, but it's going to be a long, drawn-out kind of process, but that allows supply chains to come back. I'll talk more about PP if you want me to later, because I know a lot of people are calling and asking, should we buy stuff and this and that? And if you want me to talk about that, I will later, but why don't I stop here and I'll pass it on to you.
Good. So Mihir, I like that. Good update on that. So let's go to Dr. Monica Kumar and Dr. Vivek Kumar. And for the first time, we have a couple on the call together. So let's welcome them. And they are both PhDs, pharmaceutical chemistry and pharmaceutics. So let's hear some quick introduction from both of them.
Hi guys, thank you so much, Rishi, for inviting us. So I'm actually a pharmacist by training, and I happen to be a part of a team that mans the COVID-19 hotline in New Jersey. So we actually have, we receive over 1,000 calls every day. From the lay public as well as the medical professionals. So we kind of have a pulse on what's going on, and it's not really pretty as of yet. So, but thank you for inviting us. We'd like to see what you guys have to say.
So what is the purpose of this line? What are people calling about?
So basically this line was supposed to be, it was set up by Governor Murphy, and it was originally set up to answer all questions related to, like, basically clinical guidance. So everybody there is a pharmacist, nurse, or a physician. And we were supposed to give guidance regarding symptoms, obviously, because there's not enough testing facilities available. Are you eligible for testing? Kind of help them with quarantine, we got so many calls from the emergency rooms on whether to triage. So a lot of questions, but then it ended up being questions about unemployment, questions about every single thing possible.
So a little bit of telemedicine, you would say, or?
No, it's basically just a call center. So we are just on calls, So we are actually not even authorized to, it's out of the scope of practice. So we just field phone calls and kind of direct them.
Okay. And how do you handle all the calls around like unemployment or stimulus, and how are you handling that?
So unfortunately, that's out of our purview. The only problem right now in New Jersey, at least, is that on our line is actually the only one on which they get to talk to a human being. So they actually wait online for almost 2 hours just so they can talk to somebody. And that's unfortunately the way it is. But we essentially just direct them. But they can't get to talk to a human being on any other line.
Right. So I wonder why, states don't set up these bots. We need to, like, we have a coronavirus page that we have set up at my website, rishikumar.com/coronavirus. And we have a bot there, which is basically helping us find resources that we can interact with. I wonder why not these states are establishing simple tools like that to make it easy, because, it's like if people are holding the phone for like 2 hours, I don't think so it's fair. You need a better system, I believe.
Yep. I'm
Okay,
sure there
let's
was
go
a
to
better way.
Yeah. Okay. So Vivek wants to do an introduction.
Oh, all right. My name is Vivek Kumar. I work for an ingredient supplier to the pharmaceutical industry. So we supply all the raw material that goes into the production of pharmaceutical drug products. More recently, what we have noticed is that the clinical trials in the pharma companies have pretty much stopped, and the entire focus of the industry is on designing drugs for the COVID-19 virus. And we are directly involved with a few of those companies, major big pharmaceuticals, as well as the smaller biotechs. So the trend is moving towards trying to discover and launch a COVID-19 drug product as soon as we can, like almost yesterday. So there are some big companies like Johnson & Johnson. Almost all the big pharma companies are absolutely completely focused on designing and launching a vaccine or a small molecule drug, or even a monoclonal that goes into the treatment of COVID-19 infections.
It's vaccination and drugs. And so that this will sort of get us out of this where we are stuck. So what about the raw material? When you're talking about the raw material as it relates to manufacturing of drugs, where is that coming from? Is it coming from China?
No, we manufacture it.
Okay.
So we manufacture the products in France and here in the US.
Okay. So what percentage of the raw materials have been manufactured today in the United States?
I would say not much, because US is predominantly a service-oriented economy. So we hardly do any manufacturing of both the drug products as well as the ingredients. Most of it comes either from Europe or from Asia. Yeah, we do have 3 production sites here in the US to take care of some overflow demand in the local market.
So I believe a very good investment going forward is to basically manufacture these raw materials. Start. The U.S. has to become self-reliant, and this was probably in mid-May was where we wrote an op-ed piece, and it was published on my coronavirus page, and you can all find it. But one of the things that was recommended was that U.S. needs to be less reliant upon China for the raw materials. And I think if I remember, like almost 80% of the raw material comes from China. And the push to have manufacturing brought back here in the United States is happening in a huge way from every nook and corner of America. So we can see a push in that direction, a directional shift that will take in the next few years. But I'm pretty positive that we'll see that change happening in America. Let's go to Dr. Behl. Dr. Behl, how are you?
Very well, thank you.
Thank you so much for joining in again, and I'm looking forward to having a good discussion. Would you like to provide any perspective in terms of where we are today? What have you observed? Any insights?
Yes, so as you mentioned, the California has not had as much of a surge as some of the other states, thanks to some initial um, shelter-in-place requirements and people, by and large, following those. So, given that, we haven't had a surge, but we're not beyond the peak. And as it has already been mentioned, it's going to be a long, drawn-out process. We do not have yet a very effective drug to treat the virus. Some of the promise of uh, using anti-malarials in combination with antibiotics have not been very successful. So that promise hasn't come to bear. And there is some good data on the antiviral drug remdesivir, and hopefully that may prove to be effective. In terms of vaccine, there are several candidates, probably more than 100 candidates being developed. Some clinical trials are going to start in the next 2 to 3, in fact, some in the next 2 to 3 days, or at the end of this week. For example, I read about some US Army trial and an Oxford vaccine trial. So let's see how that proceeds. But again, we have to be cautious that the vaccine can take up to 16 months to come into 16 to 18 months to be at the level that a large section of the population can be vaccinated. And that is if we actually can find an effective vaccine. And we must remember that we had to deal with SARS and MERS, and we do not have effective vaccines now, and even 15 years after the initial infection.
Really?
So it's not easy to get a vaccine. We're not sure that the vaccine will work. And if the vaccine works, if we find a working vaccine, a successful vaccine, we are still about 16 to 18 months away from mass vaccination. So those are the caveats that we need to work with.
Correct. So I was reading in the media where they're talking about that we'll have a vaccination early next year, which is barely like 8, 9 months or maybe 10 months away. Is that going to be possible at all?
So I'm not an expert on it, but going by the history of vaccinations, it seems a little improbable. But given that there is a concerted effort to develop it, and this is an international problem, and there is a coalition of governments working on it, it's possible that if we have a successful vaccine and we can mass produce it, one could see it. But I'm not an expert in vaccine production. But it's conceivable it might happen. But again, it's not something that I can comment with any degree of expertise. And I'd be very happy if we have something like that.
Dr. Behl, let's talk about the appetite we have for vaccinations, right? So we had the H1N1, we had the SARS, the bird flu, H1N1, and now we have this. I mean, those are sort of three things that I read about a lot based upon the reference to a pandemic or, from a standpoint of the scale. And the H1N1 was a lot more fatal for Americans. We had quite a few casualties, even though I sort of somehow didn't realize how grave it was because we heard about it. But these numbers, when you look at the numbers, it was quite a few mortalities back then. And what I'm hearing is that vaccination was never created for that. So either for the bird flu or for SARS, we do not have a vaccination. So what kind of hope do we have? Let's say, a miracle happens and by June, we have 0 cases here in America. Then would the appetite still be there for the industry to roll out a vaccination?
So I don't know to whom the question is directed. We're not going to have 0 cases by June. Is almost highly unlikely. But in terms of vaccination, I mean, if the problem completely went away in a country like America, yes, that's true that we may lose interest in developing a vaccine, at least certainly not emergently. but the problem is not going to go away, and we'll still be focused on trying to develop a vaccine. But it's not easy to come up with a vaccine with some of these coronaviruses, as we know, partly because of the nature of the protein, antigenicity, and various other host factors. So the vaccines usually take a long time to test, to develop, to get them to be effective, to be immunogenic, to find out if they are safe. So a lot of things have to go in. I think there was interest in developing a MERS vaccine. It's just that they were not able to develop a very effective one. That's all.
Got it. Okay. So,
Rishi, could I say something here on vaccines?
And the format is to jump in. Everybody can jump in, and we can have a good conversation.
Yeah, I think Dr. Behl, he spoke accurately on this, but I also want to add, I think we have to remember a few things with the vaccines. One is that they're really effective when a lot of people get it, so there's herd immunity, and a vaccine, for this will have a global nature. It'll take many months to get people vaccinated to a level, even locally, that we can say, hey, look, it's successful. So, I think you have to anticipate that there's going to be many months to get enough people, even locally vaccinated, for it to be, effective in terms of the population. So it's not like, hey, the vaccine's out, now tomorrow we're vaccinated. It takes time once it's set, approved to manufacture in mass scale. It takes time to get it shipped around the world. It takes time to get, medical centers ready to mass vaccinate people. So it's a long process, even after it's FDA, approved, is what I like to say.
Right. So that concerns me, Dr. Meghani, because we have to have quite a few things in place in order for us to open up our economy. And we talk about test kits, the ability to test, but also I think vaccination would sort of make sure that we don't get into a cyclic pattern of opening and closing the economy, or we basically get out from the shelter in place and boom, after a few weeks, we're like, nope, the shelter in place is back. The schools reopen and then they close again. So I think vaccination is probably the thing that we need. And, I'm kind of struggling with that as to, okay, so here is a question from Ethan. Would there be a priority for certain groups getting vaccines, or would it just be people going in to get the vaccine? So would there be some sort of prioritization or categories of people, the vaccination, in case we have?
Rishi, could I respond to your earlier question, and then maybe Monica or Rakesh can answer this, or I can answer it. But I want to touch base on what you just said though prior to this. The problem with this virus is that we don't know how likely it is to mutate. I think there are already 7 strains last time I read. So, with the influenza virus, it mutates all the time. So with the influenza virus, we basically said, okay, we're okay with not isolating people because we're okay with the much smaller risk of death. What we said with this virus is we're not okay with it because it's above whatever percent. It's 1 to 3%, 1 to 7% around the world. So we won't know really for about another year how this virus mutates and whether the vaccine that even is developed is going to be effective a year from now, because the vaccine they'll develop is going to be based on current strains. We don't know what the strain is going to be next year. I'll let one of you guys maybe answer this one, if not to hog up all the time here.
Anyone else wants to jump in?
Yeah, I was going to say the same thing, that with vaccines, one of the problems also is this, this caveat where actually giving the vaccine to somebody leaves the body more vulnerable than you started off with. And I think that's what they're saying here. I wanted to just confirm that. That was the antibody dependent enhancement. So one of the things that's also happening with this, and the other thing about this nCoV-2, as opposed to the influenza virus, was that influenza, the transmission is 1:1. But with the SARS-CoV, the nCoV SARS-2 is one person can infect 3 people. And that's why it's the transmission is a little more dangerous. It's highly, highly infective. Because with influenza, like you were saying, Rishi, it's the death rates are pretty significant, but we don't worry as much because one person can infect just one person. But with this guy, one person can go out and infect 3, and those 3 can infect another 3. So
yes, so in fact, in South Korea, in Seoul, there was this patient 31 that I've referenced many times. Patient 31 infected 1,200 people.
exactly, right?
Korea.
Yep.
Yeah, the other problem is that the spread of the coronavirus in New York City was by the young people. So they were carriers of the virus, but asymptomatic. So that is really dangerous because you don't know you are infected and you're spreading the virus. So the key to opening the economy would be to test everybody, to test and find out who is infected, who has the immunity, and who does not have the immunity. So people who don't have the immunity, they have to be sheltered until a vaccine is discovered or introduced. So without testing, we cannot open the economy. That's the key. Even if you're looking for a drug molecule, you can open the economy provided you test everybody and figure out who can spread the disease and who cannot.
Correct. So let's talk about the test kits. You know, we have the antibodies, and then we have the PCR. And so with antibodies, looks like, it is probably a great way for us to figure out if there is a herd of people who already have immunity. And
they are the first ones who can go and start working immediately.
Right. So the question is, do we know, where do we have these test kits? And is it being sold commercially, or is it, at different pharmacies, people can get these test kits, or what's going on with, let's just look at the antibody test kits.
I don't think we have enough test kits right now. They're only given to the health workers. Only to the...
So right now in New Jersey, we heard that Rutgers just came out with this saliva kit where you don't have to do the nasopharyngeal swab. You basically, so Rite Aid just started it in New Jersey. So basically you drive up, they give you a thing, you take that little vial, you spit in it, and then it's tested. The problem with these test kits is that we still, I mean, at least over here, the thing is whatever's available here, there's not too much transparency on its specificity and sensitivity. So let's say if the sensitivity is just 30%, that means 1 in 3 people will have a false negative. And that's, I think, more dangerous because then you'll be floating around thinking, oh, I'm fine. And you're not really fine. So I don't know. It's like, I guess if that's the best we have right now, that's better than nothing. But it's a little dangerous.
So not a perfect test kit. Yeah, Mihir, you were saying something.
Yeah, I think, Rishi, the other thing people need to realize about tests are, in addition to what Monica said, a test tells you how your body was at the time of the test. And with this virus, as we know, you may not have symptoms for many days. So you may not have, so a lot of times what can happen with these tests is, okay, well, I don't have it because the test is negative, but you could have it because, as Monica said, you can have a false negative, meaning you test negative, but you have it. But the other thing is that you may not have it that second. You leave a testing center, you go out to the gym, and you pick it up an hour later, so people get a false sense that, okay, I don't have it, so I can still do all of this. So unless there's a pretty wide, mass immunity to the virus, there's still a risk that you're going to get it or you're going to pass it on or that you have it. So the test is going to be helpful. I'm not saying it's not, but a lot of people in the public don't understand the limitation to what the test is telling you.
Got it. Yeah, makes sense. It's actually, for me, I'm a tech guy, and it's still like, it's clear as mud right now. So let's talk a little bit more about that. So it seems to me that the antibody test kit, what I was hearing was that, okay, it'll provide us a very specific group that is immune to it and they can get back to work. But then 30% of this group might still be positive or might be carrying. So it's probably not a good solution. So this test kit, if we even have it, and by the way, one of my good friends, Dr. Tara Rao, called me while she was driving back, and she mentioned that we don't even have swabs now. So they are using some replacement to do these tests also, which is like bizarre. I mean, what's going on here in America? We don't have swabs. So now, but we have a new test kit, what we heard from Dr. Monica Kumar. And so we are using this new test kits, but 30%. So my question is, are we going to have an antibody test kit with 100% authentic results?
I think the test kits that we are talking about with the high negative, with the high false negative rate are the PCR tests, which are really looking at the virus shedding. The antibody tests are usually more specific, and they usually are also more sensitive. So their false positive and false negative rates are quite low. But here's the caveat. Again, this is a virus that mutates.
Yeah.
So one may have antibodies to a certain strain, but that doesn't mean that one has cross immunity to another strain. So obviously the scientific way would be to find somebody who is not shedding by doing a virus test, which is the swab test, and we do a saliva test or a nasopharyngeal or a throat swab. And then you say, okay, the virus is not there, and combine it with an antibody test that says, okay, this person has antibodies. So he or she was exposed to the virus and now has immunity. We presume that the antibody does confer immunity. There's no guarantee that having an antibody, which means that we have an immune reaction to the virus, and that means we have an IgM or an IgG antibody, means that it is an effective immunity in the sense that the person cannot get infected on re-exposure. So that's one thing. And number two, having a virus, and even if one had effective immunity towards one or two strains of the virus, we do not know if another strain of the virus that has now got new proteins expressed on the surface, that the body is immune to that new strain. So all that, frankly, is going to be, unfortunately or fortunately, a societal experiment where we assume that we will have both the tests available in large amounts. And we assume that we'll be able to test at least certain segments of the population, say frontline workers, are they grocery store clerks, EMTs, police, healthcare workers, at least. And then let's say we let them go out into and say, okay, now you start working. We still might find that some of them are still vulnerable, or still maybe spreading another strain of the virus. So I think those are going to be experiments. And like we said in a previous podcast, right now, as of now, the virus is dictating everything. And it really is dictating what is happening, what we are doing, and it will do so for the foreseeable future. And we will use our current level of knowledge and our understanding to do best as we can to open the economy. We're probably going to, and it all will depend upon how many tests we have. I mean, of course, if we had ideally 200 million tests, we would test everybody. If we do not have 200 million tests, then we will be selective. Then we will get frustrated at some point with the status of the economy. And then we'll probably going to say, okay, listen, we don't have tests. We've got so many tests. We go, let's test a few and let them out and then just see what happens. So it all is something that's going to be contingent upon what we have and where our economy is and how frustrated we are, and our politicians, how frustrated they get. And they'll be pandering to their base, and they'll then be pressurizing everybody else to do what they need to do. And we're seeing that happen already. So we have politicians who are telling people to take bizarre actions, not only in this country, but in various countries. And I think we're going to see a little bit more of that, depending upon what we have and what we don't have.
Yeah, for sure. I think the frustration is building up, and there is frustration and desperation. And with that, there are some very bizarre set of actions that are playing out. But, there are some basic human needs. And, I think the US is obviously very fortunate, but there are parts of the world that are looking for just basic food and water, good water. And that's a struggle that we are sort of seeing. So it's a very unfortunate state. But going back to what Dr. Behl said, it sounds like we need both the antibody and the PCR test. And that would give us some sort of a data that would help us try to get the economy on track. But eventually, because of the mutations, the vaccination that would help. But even the vaccination, now I'm lost again. It's like, I don't see a way out. Where is the way out?
But you know what? So going back to that test, the good thing is like for HIV, the fourth generation test, that's exactly what it is. Now, HIV is not a coronavirus, but they do have that test available. It just took a little bit of time to get to that stage where it actually tests for the antigen as well as the antibody. So I'm hopeful that given time, and we will have better tests coming up, and I'm sure somebody's working on it even as we speak. So I'm sure we will eventually get one of those antigen antibody tests. But until then, it's going to be a little bit of a...
Also to me, I think coronavirus is a more dangerous virus because it actually kills people. It's maybe it is weaker than the influenza virus, but it very effectively kills people. So if they're able to prevent deaths, I think that would be a better solution than to try to discover an antigen or a vaccine or antiviral for this virus. Because we could naturally develop an immunity to these viruses. And so far, in the history of mankind, we have always developed an antibody for all kinds of viruses. There is not one known virus to man that we have not developed an antibody for. So for sure, we will be able to develop an antibody for the coronavirus. But in the meantime, if we can prevent people from dying, that could be a major step forward.
I think the problem is, at least from what all the calls we get and from what we've been seeing, there is no predicting. Like I get calls from husband-wife couples where the husband is sick as a dog and in the hospital and the wife is absolutely fine and they're both COVID positive. So I think that's part of the problem, that there is no predicting what kind of a prognosis is going to be. I think once we get a handle on that, we'll feel a little better. We have no idea who's going to end up in the hospital. I don't know if you guys are seeing something different over there on the West Coast.
Okay, I'm very limited by what I know, so I'm going to ask this question. Smallpox. Smallpox was a viral thing that happened, and we never developed any immunity to that, right? Until the vaccination came out, or anybody wants to take this up?
Yeah. So Rishi, a couple of things. I want to touch on that. Every infection we do develop immunity. I mean, just collectively. The question is, how long does it take, and each person responds. But there's nothing that we can't technically develop some immunity to. It's just a question of are we testing for that or whatever? In some way. And what does immunity mean? Immunity doesn't mean you don't have any symptom from anything. It's not a black and white. But I want to touch base on one thing about that's going to hamper us going back to normal. Just remember that the flu season's coming around, right? It just seems like it's coming around, and someone on the front line in the ER, I can tell you, it can be extremely hard in the fall, almost impossible to really say by looking at a patient, do you have influenza or do you have COVID? And if we have a very bad flu or our vaccine for influenza doesn't quite hit the mark, that's where we can have trouble. And even if there's progress on the COVID front, if we just have an unlucky flu season this year, that could really push things back as well. I'm curious what Rajesh and Monica think as well on that. But that's something that as a policymaker, everyone needs to be really concerned about. No, people are talking about COVID right now, but we need to remember the flu is going to be like a double whammy perhaps.
Correct. So let's go to I think I'm sort of channeling this conversation into basically one topic, which is how will the economy open up? because everybody's sort of like at this point, they are at the edge. And like people are just like shaking to get out and go back to the parties. Like last weekend, there was a big party in LA. There were like 500 young people who decided they wanted to party. And this is like crazy. But that's the frustration which is building up. And like our son is also so very unhappy to be at home. So how do we get out of it? But so now I was hearing an answer, which is like, we need a drug because the testing or the vaccination with all the mutation, it's not going to work. Seems like we need a drug, and remdesivir was the drug. So any comments on that, or how quickly can we expect to have a drug that'll be effective?
So as a doctor, I know that there was this leak of some University of Chicago data on remdesivir just a few days ago that was promising, and that led to the stock market going up and Gilead prices spiking, Gilead stock price spiking. We don't have a published data yet, but it seems to be promising. There are some caveats to the drug in the sense that some of the patients who are really sick from COVID, they already have renal failure, and this drug can't be given to patients with renal failure. But that's the challenge. There's hope that convalescent plasma from patients who have been exposed to COVID and now have antibodies may be of use in patients who now have the infection and not able to mount a sufficient response. But to the point that just having an antibody, we can mount antibodies to any virus, but that doesn't mean that it's effective. For example, the HIV virus. The HIV virus, almost anybody who gets infected does mount an antibody response, but those antibodies are pretty useless in fighting the virus. But they can't, so they're good for detecting the virus, but not for fighting it. Now, HIV was easier. It was a sexual contact between mostly consenting people, and you could prevent it by contact precautions. But with this airborne infection, it's a huge challenge. Where
HIV also, sorry, go ahead.
So anyway, so that's a big challenge. But again, among the drugs, I think we are. Some of it was quite for people who study science and who have been used to a very scientific approach for drug development. We saw us grasping at straws like anything that might work. An anti-malarial drug, an antibiotic, or even in vaccinations, we are hoping that BCG might work just because India or Africa have not been as affected technically as COVID, but all that may be a testing bias.
Yeah.
So we are hoping that, BCG might cause cross-immunity by causing a pan-immune reaction. So I really think that we are grasping at straws. Hopefully there'll be good data. We do know that remdesivir was effective in at least one other coronavirus. I forget whether it was MERS or SARS, but it was effective in one of those. So, and it seems to be working, at least be promising in some of the sick patients, at least given early, it seems to prevent it. At least that's leaked data suggested that most of the patients were able to come off the ventilator in that particular study, and we really need to see more than just a rumor and see published data. I think the answer will be testing and isolation, not so much as treatment, because it's going to be 1 or 2% of the patient, who really end up critically ill. The question is, how do we keep the rest of the population healthy?
Yep.
I have a feeling that we'll have to test, isolate, and maybe selectively isolate at some point. If we do not have a selective test, I think the government may be forced to make the decision that young, healthy people without comorbidities, and it's going to be say if somebody with less than 50 years of age does not have hypertension, does not have lung disease, asthma, or is not a non-smoker, you can go out because your chance of dying, you'll probably get an infection, but you'll probably get a flu-like infection, and 98% of you will be fine. So we can take a chance with you. With people who are older than 80, they'll be effectively locked up because they'll say, we don't have enough test kits, we don't have vaccines, and we do not have effective treatment. So you need to be locked up for the foreseeable future and be out of contact with this 0 to 50 age group. And then there'll be some sort of a buffer zone between those 50 years old and the highly vulnerable, where they'll say, okay, you'll have somewhat restricted. So I have a feeling that it all depends on what we have, what is in our armamentarium. And then that linked with frustration, you've got to have farm workers. Ultimately, you need to have farm workers out there. You'll have to have meat processors processing meat. You'll need to have frontline workers. You'll need to have bankers. Otherwise, we'd be actually a Stone Age civilization. So to keep it going, I think we'll have to make those tough decisions based upon what we have at the time.
Yeah, Rajesh, great points. I want to add that, you hit it right. I think on HIV, it's a very kind of long-acting chronic disease. It's not like something that's going to kill you in 5 to 7 days. The COVID, can kill you within several days or several weeks. And I want to bring up to everyone listening that vaccination doesn't totally mean you can't get the disease. Remember, people get pneumonia vaccine, get pneumonia. It doesn't cover all the strains. You can get the influenza vaccine and still get influenza. So this is not like, even if you have the vaccine, it's not like a save-all kind of scenario. And I think this is a decision ultimately for people like you, Rishi, the policymakers, to say, what's the risk we want to take? And I think in society, places like India, people make those decisions every day. I'm going to go to work when there's a flood and because I need to earn money. In America, people haven't had to make these decisions, so it's a little tough. But people will have to decide as a society, what's the risk that we want to take of people like, family members and friends dying versus people dying because they're not going to have a job and food and ability to buy healthcare and get, and pay for their healthcare costs and things like that. It's a really tough decision. And that's really what I think the next few years, at least policy-wise, the key decisions are going to have to be made around.
Yeah, and you make a great point, Mihir. We don't have structure. A pandemic preparedness plan has not been something that we have established. So our work is cut out for us in terms of, we are seeing these uprisings in Michigan where people are coming to the street. And I think we are just beginning to see that. It'll get a lot worse with the frustration mounting. And so anybody else wants to comment on that?
Well, I think Rishi, I also think we need to expect as the population density around the world increases, as there's going to be more and more of these things, because these are diseases of density, right? If you're living in a very rural area of the world and you get an infection, it's not going to spread to a lot of people by breathing. It spreads by density, and we've really built up a culture around the world of high density, living, including in the Bay Area. So viruses are going to be around. You can't defeat them. So as we prepare for this, I think as a society, we need to just think about this happening probably at greater frequencies. And, even if we get better technologically in other ways in fighting this, you cannot keep up with viruses. That's just a fact. They're extremely small and, they can mutate. That's just a fact. They've been around, from just shortly after, life formed. So I think we need to keep that in mind. But I think that the most important lesson here for people in the country is that we need to wash our hands more. We need to wear masks when we go to work. People have been very lax for years, including doctors, going to work with a cough, fever, because we have to do this. And if people at least follow a basic principle that, hey, look, you're sick, you're coughing, you have a fever, don't go to work. Or if you do go, you got to wear a mask, you got to wash your hands, and we have to be careful about spreading germs. That's probably the single most important lesson here, I think, going forward. But even if America gets it right, we have to remember something, that people are traveling all the time. So even if we get things right in California or Santa Clara County, it's an interconnected world. And because this disease spreads so quickly, it's not going to matter necessarily what we do. Everyone's got to kind of get it right, or the problems will resurface. Look at Singapore. Right? Things have resurfaced there, and that's probably what's going to happen here if we open things up too quickly. If we're willing to live with the cost of people getting sick or dying, that's something we'll have to decide collectively, I guess.
Rishi, you started the discussion on smallpox. Do we know how we got rid of smallpox from Earth?
The vaccination, right?
How was it?
Was it testing of? Because smallpox was a killer virus, right? Did we close the economy down because of smallpox virus, or we lived with it, and by testing we figured out who showed the propensity to get infected, or maybe even,
But
I
wasn't
don't
the
know
science,
how it was done. Maybe it was, we were too young
the
at that
science
time.
wasn't as advanced probably, right? To do these
Right.
test kits or whatever.
But we lived with the smallpox virus, right? I mean, we
didn't have
didn't
a
close
choice.
economies.
We didn't have a choice.
Right. But at the end of the day, it's like somebody said, it's going to be up to the policymakers like yourself. So, for example, in New Jersey, when this first started, right, everybody said that if you were exposed to the virus, you would have to be in quarantine for 14 days. So then the nurses, then as we started having a shortage of nurses, that quarantine time came down to 7 days.
Correct.
Now, New Jersey is at the point where they're telling the nurses, okay, you've tested positive, you have a fever, that's okay, still just come in and wear your mask.
Right.
So it's going to, so I think the need of the day is going to determine the policy as well.
Which is very unfortunate, because I think we can't keep shifting the policies based upon needs. I think,
Yeah.
so,
But
so
that's,
it keeps pointing me to the whole pandemic preparedness plan. I think we have really fallen apart with that. And, I'm not concerned about the rest of the world, but Greece is a prime example. They have done such a phenomenal job. They have 0 cases. They have 0 new cases. And it is the playbook that the rest of the world should adopt. It's not like every country in the world is in jeopardy. There are a few countries that have done well, and which means that the United States should have done a lot better. I'm just calling it out. I think we could have done a lot better. And I would like to go to what I think Dr. Behl was talking about. So isolation and test kits are not quite working. Is probably the only way out. And does anyone differ with that? Isolation and test kits, and it seems like we have to be hunkered down for many months, or perhaps even a year. Who knows? And that's not the answer I wanted to hear, and I was hoping that it would be a combination. So that brings me to a combination, right? In the software industry, when we write software, we are trying out this combination, that combination, to see how we can get a particular result. Is it possible that we can do this in this particular case? Is there a combination of things that we can use? And how do we even get there, right? And I'm just like talking out of my head, but can we do like ABC to see how we can get the economy open again? That's difficult. In the software industry, this is what you do all the time. You're trying to, your software is crashing, but eventually you hit that right thing by just trial and error, and boom, your software is working, right? So I don't know. That's a tough challenge. So I did want to say what Mihir pointed out earlier was with respect to spacing people out, the isolation. So now we see that, in the news we have heard that some of the economically disadvantaged communities have gotten, they are much more prone to coronavirus because they all live so close to each other. And when we look at the Bay Area, there has been push to put high density housing here because we had a huge housing crunch. Our jobs were basically increasing year to year, but we had a housing crunch. So the talk was about high density housing. So I believe that now that high density housing push will receive some pushback from people because nobody wants to be clustered here together. We want to be spaced out. And so now the talk would be to expand out housing to different other parts of Silicon Valley, like Modesto, Stockton, Sacramento, Fresno, Bakersfield, and then building out a high-speed transportation grid. So very interestingly, I saw a Mark Anderson article where he's talking about need for investment in infrastructure. This is the time we need to build the future cities of America. We need to invest like crazy, and we also need to develop better healthcare plans. So he's making some very key recommendations, like his thought leadership recommendations are, I believe, it kind of resonated very well with me. This is not the time for us to be faint-hearted, but we have to make some bold stroke moves to see how we can build a better economy, a better future for every American, but also address this particular pandemic on hand, because it sounds like we might be seeing it again and we don't have answers. So let's wrap it up. I don't think so we converged upon anything, but let's go around and see if there is what, according to you, so I'm going to put everybody in the spot here. What, according to you, is the magic formula that would get us out of this crisis we are in and get people who need jobs? Like in Silicon Valley, we have lots of white collar workers. They all have jobs and they're all saying that, oh, it's like, even if we have to be staying like this for a year, it's totally fine. But I don't think so it's realistic for us to expect that, every strata of our economic society would be able to handle the pressures of that, So what's your, like, any recommendation that you would like to make? Who wants to go first?
I guess since I'm unmuted, I'll go first. So stratification and testing. And testing with the combination, just like we have the 4th generation HIV test, we need a test like that for this, and stratification. So like somebody said, under 50 or under 55, do the test and you can go back to work.
Okay.
So I was going to just say one thing, that I do not think that we have a magic formula. We should not look for a magic formula, first of all. What we need to work on is how do we respond to a challenge in the past. And I also think that we should not be reactionary to this epidemic. And as you mentioned, a thought leader said that our goal should be to expand the cities and not look for high density housing. With a challenge du jour may be the virus, but the challenge of tomorrow may be global warming. So to forget other challenges that have always been there, whether it's forest fires or global warming, or other issues, to forget it just because of this current challenge would be, I think, a mistake. So we should not overreact and put the pendulum the other way with everything. So I really think that's very important for the thought leaders who will be listened to. And the other thing is, we have to really look at our governance structures and our healthcare. So unfortunately, I'm giving a long answer to your question about a magic formula. My main thing is, please do not look for a magic bullet for this. There will not be. We really have to change how we approach this thing in the future. So that's the answer. That's all I have to say.
I totally get it, because, I was trying to come up with an answer. It's the engineer in me who's looking at all the data and trying to connect them and come with an answer. And I was failing miserably. So I think there is no silver bullet here to address this. Though, to respond to Dr. Behl's point, the world is going to be dramatically different. And, we'll be making, like for example, oil going negative, and the travel industry. I don't think anybody will want to travel for the next year. Until we have cases around the world, nobody's going to travel. So it's going to be a huge hit upon different sectors. And there's going to be a mind shift in terms of the operating world. And so we'll have to sort of redefine a playbook for this post-coronavirus world. That's my take. Who wants to go next?
Yeah, Rishi, I'd say, in addition to what Monica Rajesh has said, I'd say that I think that one, in terms of public health, there's probably going to have to be restrictions on people, with symptoms going out, if anything's opened up at all, before, because you won't be able to tell by talking to somebody on the phone or a video visit whether someone has COVID or influenza. So if someone's got a cough and a fever, we're pretty much going to have to tell them to isolate themselves in the near future, at least, if anything's opened up. So if we open up and it's going to be like restaurants and parks with whatever restrictions on distancing and all that they have in restaurants and public transport, we'll have to be pretty strict about people not coming out if they have those symptoms. We haven't been like that before. And those things will have to be pretty tightly enforced. Otherwise, it's all going to fall apart pretty quickly, at least in the near term.
Good. Yeah, good views, Mihir. What about Vivek?
Well, to me, testing is the key to everything. And the other point would be to increase the survivability of people who are infected. So if we can give confidence to people that, yeah, your survivability is increased, you can be infected, but you're not going to die. So if that fear is taken out of people's minds, most of us will go back to working. So the infection of coronavirus would be as good as an influenza infection.
So,
So people really don't die to such extreme, levels as coronavirus right now. So, and flattening the curve is a key, because once you're flattening the curve, you give enough time to the doctors to fight the infected patients.
so what about, what was I going to say? Oh, yes. So how can we identify a very specific gene pool that that is much more at risk? Because some patients are just not handling it very well. I mean, we have heard of cases where within 5 or 6 days they are basically just like done. So what would it take for us to identify those types of profiles and not risk them?
So I'm not sure. Firstly, given that it has this virus has affected people of all races, so I'm not sure as much of the host genetic factors. At least innate genetic factors are there, inherited ones, but maybe acquired senescence of the immune system, because the fact that it's older people, so maybe there's something within the immune system, regulatory system, that is switched off or has become old and tired, and that identifying that may be a factor, and maybe some younger people may have a defect in their immune system of that sort. I do not think that there's going to be a certain I mean, there may be, we might discover strange polymorphism. Even in HIV, we know that there are certain polymorphisms that prevent people from getting HIV, even though it affects every race. We may discover one or two such, but my guess is it's not going to be very widespread, given that it can infect a lot of people, and given that it has made people very sick in all across the world. I'm not sure that we're going to find a large segment of the population with a polymorphism. We may find, say, 5% of the people, but not enough to make make an economic difference, is my guess. Again, I may be wrong, but that's my guess. But eventually, yes, because what people do is they look at, luckily we've got quick gene sequencing. We can sequence the virus, or can sequence that particular individual and say, okay, this particular thing, people with that particular polymorphism are less susceptible. But again, is it going to be meaningful? If it's only 1% of the people, it may not be meaningful in terms of opening up the economy. So we may find something that is not as, is the most critical thing in this regard. But let's see what we really find. I think the cheapest and most effective change will be everybody wearing masks. Because if everybody wore a mask, you're not going to send your particles all the way into the surroundings and not infect other people. So I think that cultural change may actually help in the near term spread the infection far and wide, even among young people who are out there supposedly in the workforce. That, I think, may be a cheaper and a sort of a cultural change that may be effective. You're not shaking hands, not coming into close contact, hugging. Those few things may change and actually make a difference in the near term until we have more effective testing, understanding. Eventually, I do think that the virus will probably die out one way or the other. The question is, how much damage does it do on its way out? Most viruses have died out in the past, and they probably will too, or at least peter out. It may become a chronic problem like the flu. It sticks around, goes up and down seasonally, infects some people. It may be that sort of a thing, but it won't probably be as much of a danger as it is now. But I think we'll just have to make adjustments.
I really like the note we are ending on. It seems like if all of us put on masks and we took certain precautions, then we could open up the economy and get everybody out there. And I'm not going to poke this anymore and just leave it at that. I would like to end on a positive note. I don't know if it's going to happen, but at least we are trying to find a light at the end of the tunnel. So I really appreciate all of you joining in, Dr. Behl, Dr. Vivek Kumar, Dr. Monica Kumar, and Dr. Mihir Meghani. I really appreciate all of you taking the time to join in. We had a good discussion. This video will be posted on YouTube. We'll share it with our followers and get get any more questions. So we'll regroup again next day with the reality check for Rishi. We'll talk a little bit more about the burning issues around coronavirus. Thanks for taking the time. Really appreciate it. Enjoy the rest of the evening. Bye.
Thank you.